Oh, okay. I'm going to give you some background information on neuromuscular disease. You know, you don't have any neuromuscular disease clinic here, do you? So you don't really see a lot of people with spinal muscular atrophy or muscular dystrophy, or how about how about ALS? Do you see people with ALS? Not too often? Oh boy. Okay. So look, let me tell you a little bit about these conditions then. Boy. I like to start with birth, start from the beginning. If you have a floppy newborn, 80% of the time they develop normally, but 20% of the time they don't. So 20% half of those kids have cerebral palsy. If you've got an infarction of the cerebellum or something, often these kids are floppy. The other half the time, the kids have neuromuscular disease. Now, by far the most common neuromuscular disease that presents as a floppy newborn is spinal muscular atrophy. 1 out of 5,000 kids are inherited spinal muscular atrophy type 1. It's the most common cause of sudden infant death syndrome, and it's often not diagnosed until the kid is dead. They do an autopsy and they find out that he doesn't have any anterior horn cells. Sometimes these kids are not so floppy that it takes the attention of the pediatrician, that it captures his attention, you know what I mean? But then they go on and they die from SIDS. Those who are diagnosed, well, I'm going to be talking about those. Now, these are the other conditions that can present as floppy newborns. Congenital myopathies, congenital muscular dystrophies, myotonic dystrophy, and so on. Pompei's disease is one we see quite often, actually. Yeah, this is the order of incidence of these conditions in the floppy newborn. Okay. Now I'll show you what these kids look like. They have absolutely no tone. They're floppy. You pick them up and their arms just go right through your hands, and they slip down, and that's what they look like. Now, SMA has been described in terms of 5 types. The type 1 is where the kids are so weak that they can never roll or sit. So they can never sit. That's SMA type 1. If they can sit independently, like this little girl, it's SMA type 2. If they can walk, now they may only be able to walk for a few months, or they may be able to walk for 20 years. But if they can walk, they're SMA type 3. And there's an adult onset SMA, type 4. Now, Stephen Hawking, it's not clear what he has. He may have adult onset SMA, because after he was diagnosed with motor neuron disease, he walked for another 10 years before he needed a wheelchair, and then he breathed for another 10 years before he went into respiratory failure. He's now been on trach ventilation for 30 years. He got trached in 1985. So although that's, ALS, we know now, is a combination of many, many genetic abnormalities. It's not just one type of motor neuron disease, ALS. There may be hundreds that we lump together and call ALS. And we call it ALS when we don't find any abnormalities in imaging and when the EMG shows membrane instability. So we call that ALS. And also for amyotrophic lateral sclerosis, it implies that there's upper motor neuron as well as lower motor neuron, okay? So basically the diagnosis of ALS or of motor neuron disease is made by everything else being normal except the EMG showing membrane instability. So really there are 3 big categories of anterior horn cell disease. There are the spinal muscular atrophies, which are inherited on chromosome 5. They're autosomal recessive. There's motor neuron disease. Now, motor neuron diseases, ALS is one of them. And 10% of ALS is inherited, autosomal dominant. But you can develop generalized motor neuron disease if you have AIDS. Certain metastatic cancers can cause that. If you have monoclonal spikes on your immunoglobulin electrophoresis, that can cause anterior horn cell disease. And if you treat the primary problem, if it's immunological or if it's AIDS, for example, or if you remove the cancer successfully, the motor neuron symptoms can actually disappear. So that's the thing that we look for when we see patients with anterior horn cell disease. The third category of anterior horn cell disease is really the viral, like myelitis. Like, for example, poliomyelitis, as you probably don't know, there were 3 polio viruses that cause polio. There's also the Coxsackie virus that can cause polio. And I don't know if you're aware of it, but I wasn't aware of it until a couple of weeks ago myself. Last year in Texas and in the Southwest, there were almost 200 cases of polio that they think was caused by an enterovirus. That hasn't been confirmed, but clearly it occurred 1 to 2 weeks after a viral syndrome. So it's clearly a virus, okay? And these kids, these people, 1/4 of the patients were adults. So most of the patients were kids. But there are viruses that can cause anterior horn cell disease. The polio viruses, Coxsackie virus, and maybe the enterovirus. So as I mentioned here, kids with type 1 never sit. Now, sometimes they call Kennedy's disease a fifth type of spinal muscular atrophy. Kennedy's disease is a sex-linked recessive endocrine disorder, basically. There are men who have, well, they look a little bit like myotonic dystrophy with frontal balding. They have hypogonadalism. They can have other endocrine disturbances. But it's adult onset anterior horn cell disease, and Kennedy's disease is sometimes called SMA type 5. Now, any child, any of you going into pediatric PM&R? Nobody? Ooh, I'm surprised. Usually there's a couple of people, you know. Well, any child that has paradoxical breathing, you have got to put them on nighttime ventilation, or their lungs will not grow, their chest will be like funnel-shaped, and they will develop pectus excavatum. So now I'm going to show you some examples of that. Well, there's an example right there. So this kid is about to die. He's 1 year old. He has SMA type 1. This is a photo from a textbook by a very highly regarded British neurologist who shows exactly how not to treat a patient. Even though the neurologist knew, because he'd heard people speak about it, including me, that you can put these patients on ventilatory assistance during sleep and their chests will expand and their lungs will grow. He just never bothered to do it. Because there are a lot of physicians, and not just in Britain, but in the United States, who feel, and you may also feel this way, that these kids should be allowed to die. There are many neurologists in the United States and all around that feel that the parents, no matter what they want, it's not important, they're not realistic, just let the kids die. And personally, I feel as physicians, we should do what the parents want. Personally, I feel that way now. Generally, the parents are very attached to these kids, and they want to help them. There are really three strategies you can use for kids with severe congenital neuromuscular disease, like SMA type 1. You can say to the parent that the kid's going to be severely disabled all their lives, and it's slightly progressive, and that's the way it is. They'll be vent dependent for their whole lives, okay? So you could let nature take its course. Now, what does that mean? Well, first of all, these kids lose the ability to eat. It's rare for anybody to refuse a gastrostomy tube and let somebody starve to death. So that's pretty rare. Now, once they get a gastrostomy tube, the next thing that happens is, in the severest type of SMA type 1, the patients become 24-hour vent dependent before they're 6 months old. And you see they get into some distress, they have nasal flaring, and they develop hypercapnia, and they will die. This is only about 10%, however. Now you can put them on, I put them on non-invasive ventilation at home, and they live. But if a family wants to let them die, they just have to let them die. I don't know what else to say. So anyway, the other thing is most of these kids survive until after 6 months of age, when they're not, when they don't have access to their mother's immunoglobulins any longer. They get an RSV or some infection, they get pneumonia, go into respiratory failure. But then what do? Well, you have to tell the parents, okay, don't bring your kid to the emergency room or call EMS, because if you call EMS, they're going to give you oxygen. The oxygen will shut off his drive, he will arrest, and he'll have to be intubated emergently. Now, if you call EMS or go to the emergency room, that's what they will do. Now, if you want to let the child die, you cannot bring him there. Now, can you make him more comfortable? Yes. You can give him oxygen. Of course, the oxygen will shut off his drive and he'll arrest. I don't know if that really makes you more comfortable. The other thing, of course, is you can give a child narcotics or sedative medications, and that will kill him a little bit faster. But anyway, that's one strategy. That's one option, right? Now, the second option, which I find no reason for really, is tracheotomy. Because 20 years ago, I told my patients that if they didn't get trach, they'd be dead within a year, and they're all still alive. So you don't need a trach for the worst neuromuscular disease. You don't need any trachs for anybody. There's only one exception. The exception is when you have upper motor neuron spasticity in the throat, which happens to everybody eventually with ALS. So in other words, nobody with any kind of muscular dystrophy or spinal muscular atrophy or any other kind of neuromuscular disease ever needs a trach tube. For that matter, nobody with spinal cord injury needs one either. They can always be removed unless there's brain injury and there's spasticity in the throat and the patient cannot cooperate, okay? So anyway, this kid didn't get it. I'm sure he was dead a few weeks later or a couple months later. Now, this is severe. Some people call this type 0 SMA type 1 because they were event dependent from 4 months of age. And I told the parents of this boy that their kid would be dead within 1 year if he didn't get a trach. But then when he was 2 years old, mom got pregnant again. And being a good Catholic, she decided whatever God gives her, that's what he wants her to have. Well, God gave her a second child with severe SMA type 1, 24-hour event dependent since 4 months of age. And unfortunately, they don't have any other kids. They only have these two, you know? I mean, they have no other kids who are not affected. It's really sad. Dad is a lawyer. Mom is a wonderful person, intelligent, everything. But they only have these two kids, you know? Oh, by the way, that's sort of what they look like in 2010. I'll show you what they look like now in my next talk, you know, after this one. So, disease of anterior horn cells, I told you, spinal muscular atrophy, polio, and ALS, or motor neuron disease. The polio viruses I told you a little bit about. There are 3 of them. There were still almost 2 million post-polio survivors in 1987, and so on. But polio is, you know, the physicians at the CDC are really worried that this year there will be a significant polio epidemic in the United States because of this perhaps enterovirus, you see? And there was a big article I read about that recently. This is polio, 0 vital capacity for 52 years. Now he's got a sip and puff motorized control wheelchair, right? Motorized wheelchair. He's got his ventilator on the back. And now where is the tube going? Where is it going? How is this guy breathing? Don't feel too bad if you can't figure it out. I brought him to a pulmonary conference in Toronto, and none of the pulmonologists could figure it out either. None of them. How is he breathing? He's got nothing in his nose, his mouth, or his neck. Now, he does have a sip and puff control of his wheelchair, but he's not being ventilated through that, okay? Okay, so come on. If any of you figure this out, you're better than the pulmonologist in Toronto. Come to think of it, we happen to have a pulmonologist here from Spain. I suppose it's only fair to ask you to them. Any idea how he's breathing? No, no. Well, I'm not surprised. Don't feel so bad. Don't feel bad. He's got an intermittent abdominal pressure ventilator. I'll talk a little bit more about that later. Well, maybe I should. Maybe I'll just tell you now. This is going into an air bladder inside a girdle. The air bladder pushes against the belly and it moves the diaphragm and ventilates the lungs. He used this for about 40 years. Now, I already told you most of this. None of this stuff is really very, very important. The fact of the matter is that everybody with ALS eventually gets bulbar. You can start non-bulbar, you could start bulbar and then get limb involvement, right? But the fact of the matter is, as long as they're non-bulbar, there's no danger. Because 42% of our patients become 24-hour event dependent without ever going to the hospital. With ALS, I'm talking about. Because they are non-bulbar, so they can use non-invasive ventilation. However, the other majority of patients, unlike all the other neuromuscular patients, including SMA type 1, they get so bulbar that you hear stridor. And it's not the bulbar involvement that prevents non-invasive management, okay? Because I told you, the SMA type 1 is now 20 years on 24-hour non-invasive support. they have zero vital capacity. So it's not the bulbar involvement. They have no bulbar muscles, these SMA kids. In fact, they have no muscle movement anywhere. The only thing that separates them from being totally locked in is that their mother there sees a trace of eye movement, and she knows if they're saying yes or no. I do not see that movement. I don't know how she knows this, but she's been doing this for 20 years, and I guess somehow she sees a little bit of movement of the eye. But these kids, they have absolutely no movement, nothing, anywhere, except maybe 1 millimeter of eye movement, which I cannot see. Okay, what about the muscular dystrophies? The most severe, most common neuromuscular disease, I shouldn't say the most severe, but it's the most rapidly progressive, is Duchenne muscular dystrophy. It's a sex-linked recessive. It's a XP21. X, of course, is the X chromosome. P is the little arm, petite arm, and the 21 site. Usually there are a bunch of exons that are affected from 46 to 53. You can have a point mutation. You can have a deletion. It doesn't seem to matter much. It causes the same problem. If you do a biopsy and you have more than 3% of dystrophin, then you are called Becker muscular dystrophy. But it's the same defect on the genes, okay? Often people with Becker don't even know they have it. They may be adults and maybe be a little bit slower than other people physically. Then they go for surgery and they develop malignant hypothermia. And then they discover that they have Becker muscular dystrophy. So Becker can be almost as severe as Duchenne, or it can be so mild that you become a young adult before you even realize you have it. So it's very, very variable. But Duchenne is not so variable. It's not so variable. The kids are in wheelchairs between 6 and 12 years of age, and they usually need ventilatory support by 20, even younger. They all have cardiomyopathies, all develop cardiomyopathies. However, nowadays, our patients are living into the 50s now with Duchenne muscular dystrophy. 30 years of 24-hour non-invasive ventilatory support, but they live into their 40s and 50s. What gets them is their heart. So beta blockers and ACE, well, I'll talk about that in a couple of minutes. These are the other muscular dystrophies. The autosomal recessive types, we call that limb girdle, but now there are more like 20 genetically distinct defects that cause this limb girdle muscular dystrophy. The thing about limb girdle is that the patients have normal intelligence, they have very little bulbar muscle involvement, so they do extremely well. None of them, therefore, ever need tracheotomy tubes, and so on. And most of the congenital muscular dystrophies are also autosomal recessive. The main autosomal dominant muscular dystrophy is FSH, facioscapulohumeral muscular dystrophy. Now, many of these patients don't start off with any facial involvement. So don't be surprised if you have a patient with scapular winging, especially the serratus, and they have no facial muscle weakness, okay? It doesn't matter. They often don't have any facial muscle weakness, at least early on. But classically, they have terrible winging, and you can staple the scapulae to the rib cage, and then they can move their arms much better. And in fact, you can do this on your own. If you ask the patient to raise their arm, and then you push the scapula against the cage, and you hold it there, and then you see, oh, the arm goes all the way up. See, because the deltoids are very strong, usually. So I'll show you a photo of these. Now, other autosomal dominant conditions, distal muscular dystrophy, which I've never seen. Oculopharyngeal muscular dystrophies are not that rare. Myotonic dystrophy is extremely common. And myotonic dystrophy is sort of an example of genetic stuttering. They have a 3 sequence that is repeated thousands of times. And the upper limit of normal is, I think, about 20. And now this is limb girdle muscular dystrophy. And you see that the extremities are very atrophied. Emery-Dreifuss muscular dystrophy. Questions on exams. This one sometimes pops up because there are 2 things in the neurology literature that they say are specific about Emery-Dreifuss. One is they have wide carrying angle, in other words, they have severe contractures even though they don't have much muscle weakness, okay? That's what the neurologists say. Now, in my opinion, contractures are caused not by muscle weakness, but by an imbalance of strength. Honestly, I don't know if that's also true for Emery-Dreifuss. I think it probably is, but you know, it's the imbalance of strength at the joint that causes the contraction. The stronger muscle contracts, okay? And that's what happens. But in the neurology literature, they say that despite relatively good strength, these patients get a lot of these contractures. And I guess that's possible, but that's one of the things. Now, the second thing about this condition is that they are highly susceptible to malignant arrhythmias. And that's always a very popular question, because those are the two things distinctive about Emery-Dreifuss muscular dystrophy. It's a defect of lamin and emerin, and you know, at times these patients have been confused with Duchenne, so they can be pretty severe. Usually it's considerably milder, as you can see here, and also it affects females. You know, so congenital muscular dystrophies. Now I'll tell you, this is kind of an old slide. They've had a lot of success at characterizing the congenital muscular dystrophies, and they know a lot more about it now than I know about it. I haven't really updated this stuff. But these patients are often born with severe contractures, and it's called arthrogryposis. The thing about congenital muscular dystrophies are that usually they're non-progressive. They're static conditions. So these kids may never walk, but usually they do. Usually they walk late, and unlike Duchenne muscular dystrophy, they don't seem to progress. So they actually do quite well through adulthood and so on. Now, this is a woman with congenital muscular dystrophy. She had two brothers. One died at 18 years of age from respiratory failure. The other was trached at 18 and died from 29 years of age from a hemorrhage from the trach tube. 4 out of 5 people that go on trach ventilation die because of complications of the trach tube. And like I always say, in my opinion, you're not doing rehabilitation if anybody leaves a rehab service with spinal cord injury and a trach tube, unless they're not able to cooperate, they've got also severe brain injury. Nobody with spinal cord injury who can cooperate should ever need a trach tube. And the reason why it's so bad is because when you're ventilated through a trach tube, you're always frightened of two things: an accidental disconnection, and often the low pressure alarm doesn't go off and you die, or the ventilator failing. Now, if you're managed without a trach tube, you can always learn how to frog breathe. 70% of spinal cord patients frog breathe sufficiently to ventilate their lungs all day long just by frog breathing. I'll show you that. Why don't I show you now, since I started talking about it? Since I'm very tangential, I might as well continue with the tangent, right? I was going to tell you this anyway with the next lecture, but now, you know, I don't wear this just to be fashionable. You know that, right? This is, like I always say, it's an instructional tie. I've said that last time too. This is, you know, frogs don't have diaphragms. They actually breathe the way I'll show you. Now, I teach my patients, I tell them to imitate me, and that's all you have to do. You imitate me and you learn how to frog breathe. And let me tell you, you guys living in Philadelphia, you certainly better know how to frog breathe, because the traffic here is pretty bad. And if you get whacked into and become a C1 quad and don't know how to frog breathe, you'll think about me in your last thoughts. Your last thoughts. So I should have learned from Dr. Bach how to frog breathe. Look, you do it this way. There's two things you could do. You could go to your functional residual capacity, which is where you're totally relaxed, or you can take as deep a breath as you can and frog breathe on top of that. So if you go to your maximum inspiratory capacity and frog breathe, you'll feel a point where you cannot gulp another cc of air, because everybody can get a much deeper vital capacity by adding frog breathing on top of their inspiratory capacity. So for example, frog breathing, as you may not know, is a sports medicine technique. For example, all world-class sprint swimmers are excellent frog breathers. And did you know, does anybody know this? Well, I'll tell you why. See, because when you swim 50 meters, you don't breathe. You take a deep breath, you jump in the water, you swim 50 meters, you come out, and then you breathe. Now, the breathing is not the problem, because the usual athlete that can do this has 7 to 9 liters of vital capacity. So they take a real deep breath and they swim. But the problem is that the more air you put in your lungs, the more buoyant you are. The more buoyant you are, the higher you are in the water and the faster you can swim. I have seen this myself, because I was at, and I think it was 2009, I was at the Interplanetary Conference on Frog Breathing. It was in Milan, Italy. They called it international, but I called it interplanetary because I was hoping some interplanetary frogs would come down who might have been interested in human breathing. But unfortunately, none of the frogs showed up, you know? But so these athletes in this conference demonstrated some remarkable things. For one thing, a swimmer whose vital capacity was 9 liters, frog breathed up to 14 liters. Now, could you imagine putting 14 liters of air in your lungs, you know? And then he swam underwater for 10.5 minutes, which, by the way, is not nearly the world record, okay? The world record is 17 minutes. So I bet there are some whales that would be envious of that, you know? The other sport that I know of where frog breathing is very important is in free diving, because when you go down more than 200 feet in the ocean, your chest wall is totally collapsed. And the more air you put into your lungs before you go under, the better off you are and the longer you could stay down there. But there's another thing that they demonstrated for me, which was amazing. They actually reverse frog breathe. I think I was able to do this once, but I don't know. I can't do it now anymore. I mean, I don't. What they said is that when they're a couple hundred feet under the ocean, if they don't equalize the pressures in their eustachian tubes by bringing air up, they lose consciousness. And they actually reverse frog breathe from their residual volume to equalize those pressures, which, you know, is incredible. You know, I have never yet seen a frog reverse frog breathe, okay? So anyway, so frog breathing is very, so why don't you try this now? Now, I usually tell normals to rest completely, go to your, the functional residual capacity where you're not using a diaphragm, and then take maybe 15 gulps quickly, and then exhale passively. And the air that you exhale, you will have gotten by frog breathing, okay? So don't use your diaphragms. I can always tell when you're doing that. I can tell. So don't use your diaphragm. Just exhale passively, and then yeah, both of you guys are doing it pretty well. Ooh, you get that beard there, it's hard to see, but you also do well. No, you feel the air, you too, all of you. You feel the air, right? Now, if you take a real deep breath and you frog breathe on top of it, the first time you do that, if you check your vital capacity, say it's 5 liters, right? Most people, the first time they go to 5.5 liters. I can add 1 liter on my vital capacity. But like I told you, people who practice this, they add 5 liters onto their vital capacity by frog breathing, which is, you know, amazing to me. No, they do it, they get 200 milliliters per gulp, and this is how they go. That's 10 gulps, okay? So you get 200 milliliters per gulp, that's 2,000, you see? When you first started, you only get about 60 to 90 milliliters per gulp. But with practice, you get better and better. And these athletes, you know, I had a kid come to me from North Carolina. He was 19 years old, and he won the state sprint swimming championship. And he had a spinal cord injury. So I really saw him because of a spinal cord injury, and he had a trach tube. So I told him that I took out his trach tube, and after the site closed, his frog breathing capacity was terrific. I forget what his vital capacity was, but he added a couple of liters of air on top. And I said to him, you know, you were the state champion swimmer, and I said, do you know why you were the state champion? I said, do you frog breathe before you? He said, absolutely. He says, you know, so he adds a couple liters of air. And I said, well, the other people on the line with you, did you see them frog breathing? And he said, well, no, I don't think so. So I said, that's why you're the state champion, because he was able to swim faster because of the frog breathing, you see? Anyway, back to this woman here. So she had one brother die at 18 from respiratory failure. The other brother got trached and died about 10 years later. She now is 50 years old. She's been a 24-hour event user. Now, this is the lip seal that she uses at night, but she uses a mouthpiece during the day, and she's been doing this now for about 30 years. Facioscapulohumeral muscular dystrophy, 95% of these patients have the autosomal dominant adult onset type. But there are also juvenile and infantile forms of spinal muscular atrophy, which are usually autosomal dominant, autosomal recessive. So I just want to let you know that. It doesn't have to be autosomal dominant. This is classic FSH. Now, when the facial muscles are involved, which is usual, the patients often look very young because they don't develop any wrinkles, because they don't have any facial expressions, because they, in fact, they can their lips can even get so weak that they cannot grab a mouthpiece to ventilate their lungs. And so, like, this woman here is 83 years old. And I'm just joking, okay? But really, they do look much younger than other people, you know, their age. Myotonic dystrophy is kind of bizarre. Let me show you what they look like. They have frontal balding, temporal atrophy, dolichocephalic faces, okay? And they're apathetic. They're the kind of guy, you girls who have boyfriends, when you go to their apartment and they have a pile of pizza, empty pizza containers, you know, they may have myotonic dystrophy because they just, you know, let these things go, you know? So that's how they are. They develop cataracts, ptosis, impaired gait. They have general endocrine problems too. They have hypogonadalism and thyroid abnormality, you know, and any endocrine disturbance. They develop cardiomyopathies also, and so on. All right, so back to Duchenne. I don't know if I want to talk about it anymore. I told you enough about it. One thing I should tell you, that the average IQ is 89 to 90. However, there are patients with Duchenne with IQs of 130, and of course others with 50. So we've had several Duchenne patients become lawyers. 3 become lawyers. 1 became a physician. And we've had a number of our Duchenne patients have married. Now, when they have sons, their sons are normal. But when they have daughters, they're automatically carriers, okay? So they don't have kids that are affected in general when they have children. We've had patients, I know one guy, his wife left her husband, her first husband, in northern Canada with 2 daughters and came to New Jersey to marry him. You know, I think she was fed up with her first husband because he wasn't faithful to her, and she figured that a disabled husband might be more faithful. Well, let me tell you, she was wrong. She was wrong. I can give you plenty of examples, you know. It doesn't work that way. It doesn't matter if you're severely physically disabled, you have all the normal vices of the rest of us. By the way, what I tell my medical students, my female medical students, I say, you know, remember this, the best men are bad and the average is terrible, and there are no exceptions, okay? So that's what I tell them, and that's one of the things I tell them, you know? Anyway, this is a Duchenne patient who is 48 years old. I guess I'll show him again later on. Becker is 1/5 as common as Duchenne, and it's much more variable. Now, talking about managing these conditions, I like to separate it into 3 stages. It's important to, the ambulatory stage is the first stage, and really the most important thing there, I tell the parents of these kids when they will have to make decisions about what to do for the entire future. Now, once they've accepted the fact that their kid has spinal muscular atrophy or muscular dystrophy, I say that you'll have to decide if it's Duchenne, if you want him to have steroids, if you want them to have lower extremity surgery to prolong brace-free ambulation, if you want them to have scoliosis surgery, if that becomes necessary, and if they don't take steroids, it almost always becomes necessary, and about non-respiratory management. So I tell them the whole future, you know. And every time they come, I sort of review that. So when it comes to making the decisions, when it comes time, they've heard about it for so long that it's easier for them to make the decisions. And so the other thing that's very important is to counsel them, to tell them not to treat their affected child differently. Don't overprotect them, because when you don't overprotect your disabled child, the other children in the family become extremely mature. They say to themselves, gee, that could have been me, and they help out with the disabled child, and they really are far more mature because of it. I don't think there's any doubt about that. You know how immature children are. I mean, video games and, nowadays. When you have a severely disabled child in the family, and he's your brother or sister, the other kids, now if you overprotect, or if you give all your attention to the disabled child and you neglect the others, then of course it's completely different. Then you have problems with the unaffected kids. So this is very important in terms of the family psychodynamics to discuss with the parents, because many of the parents do, unfortunately, ignore their unaffected kids and spend too much time. And in fact, they bring their disabled child to 1 billion doctors, Frankly, they shouldn't need anybody. The neurologist can make the diagnosis, then they see their pediatrician. Now, the books that I write, the idea is that one physician who does this stuff should be able to handle 95% of all the problems. So for example, there's no orthopedic surgeon in my clinic. When I want our orthopedic surgeon to do extremity surgeries, which I'll tell you about, or scoliosis surgery, I send them to the orthopedic surgeon. I start my patients on cardioprotective medications, and I do all the respiratory management. I also have PTOT and speech around me, and I get them involved, and so on. So, it's not realistic to have an army of doctors, but sometimes the parents take their kids to orthopedic surgeons anyway. The cardiologist will repeat an echocardiogram every 6 months just to make a buck. There's absolutely no reason to do it otherwise. And it goes on like that, you see? So they spend so much time doing useless stuff and over-treating their affected child that they may ignore the other kids. So I also remind them, if you go to a physician, you may get better. If you go to 2, you're probably going to get worse. And if you go to 3, you're going to die. So, I point that out to them, and I tell them to stop taking their kids to every physician in the world and spend quality time with the kid. Stop treating the kid as though he's sick. And because, sickness is psychological more than anything else. These kids, even the SMA type 2 children have an average IQ of 120. And they can accomplish fantastic things. But not if you overprotect them and don't encourage them to set goals for themselves and do well in school. So then I talk about a stage of wheelchair use, which mainly we want to prevent scoliosis. That has to be done surgically, and to facilitate ADL. And then the third stage is managing cardiopulmonary stuff and ADL, So let's talk about pathokinesiology. A Duchenne patient, but this also holds for SMA type 3, kids who can walk with SMA, and other myopathies and muscular dystrophies. What happens is they develop an imbalance of strength in the lower extremities, okay? And in particular, the first thing you see is increased lordosis. Why? Because the hip flexors are stronger than the hip extensors, so they rotate the pelvis forward, okay? So you see an increased lordosis. That's the first thing you see. Then you see heel cord tightness, and eventually you have a little bit here of hamstrings tightness, okay? So again, the hamstrings are stronger than the quadriceps, and the plantar flexors are much, much stronger than the dorsiflexors. This is what you see. Now, what stops them from walking? Ernie Johnson, who is a legend in our field, and I feel privileged to have known Ernie Johnson. None of you have ever met him, did you? No. Oh, you met Ernie Johnson? He has a book, Ernie's Quips or something like that, sayings. He was a brilliant physiatrist. And the thing that was amazing about him was that he wouldn't assume that common sense was true. So I remember one lecture he gave in our review course, where he was talking about post-musculoskeletal injury to exercise the joint and the muscle immediately. And, he kind of shocked everybody, And then he backed all of this up with information and showed that there was no data against what he was saying. I mean, he did things like that. My first experience with him, I was a little younger than I am today, and I gave a presentation in Georgia at Warm Springs. It was a polio thing. And there was a very famous electrodiagnostician by the name of Jasper Dalby, who has written many books on electrodiagnosis like Ernie. So Jasper gave a talk, and after his talk, Ernie lambasted him, said that this was completely worthless, it was useless, and he gave up. So then Jasper said, well, I want to defend myself. He said, no more time. No, there's no more time. Next talk. I was the next speaker. So my topic was frog breathing, okay? And this was 1970, I don't know. It was around 1970, late 1970s. So I gave my talk, and the first hand up is Ernie Johnson. So I'm thinking to myself, okay, I'm ready for him, okay? I turned towards him like John Wayne, and this is exactly what I was thinking. This is exactly, and I was expecting, I don't know what I was expecting after what I heard, but he did with Jasper. And he said, oh, wonderful talk, I agree 100%. I just wanted to point out that frog breathing can at times be done with the presence of a trach tube. And I was shocked. I said, well, oh, yes, of course, yes. But of course, the air can leak around the outer walls of the trach. He said, oh, yes. So that was my first experience with Ernie. But Ernie did this work on the pathokinesiology of the gait in Duchenne muscular dystrophy. And I believe this material comes right from one of his papers. But really what it comes down to is, like I told you, when you have an imbalance of strength at the joints, if you walk around all day with 30 degrees of contractions at the knees, you're not going to walk that far, even with normal strength. I think you realize that. You are going to see people in your careers who have practically no strength, no anti-gravity strength in their lower extremities walking. They can do that because they have no contractions, and maybe because they have good triceps, so that if they fall, they don't kill themselves. But these kids have difficulty walking because of contractures and because of a weakness, okay? If you eliminate one, you can't eliminate the weakness, but you can eliminate the contractures. And you can do that by moving muscles to balance the strength at the joints. So in early 1980s, I went to France to teach them about non-invasive ventilation. And I worked with a physiatrist by the name of Rideau. He taught me basically all this pathokinesiology stuff and operating on these kids very early to prevent contractures in the first place. Because when you have a contracture, the strong muscle is pulling the weaker muscle out of its optimal length for contraction. And it's making the weaker muscle weaker. And really the big problem is that if you have contractures in the legs, you fall more, right? So what happens? When the legs get very, very weak, the person has to keep the center of gravity in front of the knee. If it goes behind the knee, they jackknife, right? But they also have to keep the center of gravity behind the hip, because if it goes in front of the hip, they fall forward, okay? So they got to keep the center of gravity in front of the knee and behind the hip, and they end up walking something like this, and they'll have to bob their head. Well, what stops them from walking if they don't get operated on is when they develop contracture of the hamstrings. Because if you get a contracture of the knee, it becomes impossible to keep your center of gravity in front of the knee and behind the hips at the same time. That's why they stop walking, okay? If you prevent the contractures, these kids walk an extra 15 months. I published that years and years ago. And what you have to do is, the fascia lata is the outer part of the iliotibial band is the outer part of the fascia lata. But the fascia lata goes around all the muscles in the thigh. And it squeezes them. It causes like a compartment syndrome, basically. It squeezes them. I've been at the surgeries, and I've seen how thick this material is, right? So what they used to do is they would slit the iliotibial band at the knee, but after a couple of weeks, the connective tissue would overgrow it, and you still have the contraction. So what I learned in France was wide resection of the iliotibial band. And then the kids, because the iliotibial band causes the wide base gait and internal rotation of the knees, okay? If you eliminate that, they walk with their legs closer together, right? And without the internal rotation of the knees. So a wide resection of the iliotibial band. Now, we measure the iliotibial band You may have been taught to do it with the patient lying on their side and you bring the leg back. That's a classic way to teach, but you can't really quantitate it that way. This is the way I measure the iliotibial bend. You put the patient, bend the knees 90 degrees and measure the angle from the sagittal plane. This iliotibial band looks more contracted than this one. And when you have a more contracture of one side, it brings the pelvis down. So the scoliosis is going to go that way, you see? And so you can sort of predict most of the time how the scoliosis will develop. Now, when I was doing the oral boards, I would ask questions like, how do you manage scoliosis and stuff like that, or what causes scoliosis? Well, let me tell you something. Scoliosis in these patients is caused by weakness of the paraspinal muscles. And nothing you can do, I mean, if you brace these kids, you may keep the curve more reversible for a better surgical correction. But you're not going to prevent scoliosis with bracing. So you don't brace patients with Duchenne. Because if they're 10 years old, you can operate on them and they'll be better. Late surgery was reported earlier, and when I say late surgery, I mean the British were operating on these kids after they were in wheelchairs, then they'd have to put them in long leg braces, and they could just never walk again. I don't recommend late surgery. Now, again, we do a wide resection of the iliotibial band. We do a release of the hamstrings, tendo Achilles lengthenings, and release of the tensor fasciae lata that inserts into the iliotibial band. But the other thing that I almost always ask the surgeon to do is a tibialis posterior transfer. You know very well there are three muscles that are plantar flexors of the foot, right? Well, one of them is the tibialis posterior. The tibialis posterior also internally rotates the forefoot, right? So you test it by simply putting your hand together to tell the patient to go in that direction, right? It's always very strong, just like the soleus and the gastrocs. So if you take that muscle and you put it through the interosseous membrane and attach it to the second or third cuneiform, you have just as strong plantar flexion and dorsiflexion. They're equal in strength. And you have a normal foot for the rest of your life. And it permits these kids to walk an extra 15 months, which we reported in, my goodness, 1991. Whew. And the Germans reported 250 of these cases in 1999. So it does work. We cast them for a week, and then they get a lot of physical therapy for a couple of months, and they do well. Mostly it's outpatient physical therapy. And when they're 9 years old, instead of looking like the kid on your left, they look like the kid on the right. And so on. And they can walk. And I mean, this is one case actually from France. But this kid was operated on late. He had fixed contractures. The contractures were not completely corrected. When you have contracture for a long period of time, you cannot release it by tenotomies. You have to do a capsulotomy, which is a lot of surgery, and nobody ever will do that. So, you know, it becomes a problem. And anyway, there's a pre-treatment and then post-treatment and so on. Okay, I want to go through some other topics here. But this was a woman with Turner's Duchenne. She actually had XP21 muscular dystrophy because she only had one X chromosome. But you see, she had a very, very nice correction. She had to hold on to somebody to walk, and then after the surgery, she's very good. If you wait until the patient's in a wheelchair and you do this, the patient still may not be able to walk, except with something to brace the knee. So they don't fall any longer, they walk slower, it restores standing balance, long-term contracture relief. They don't need physical therapy. Really, they don't need so much physical therapy at any rate. Decreased physical therapy requirement, they ambulate without bracing, and it prolongs their brace-free ambulation. Ankle-foot orthotics are only useful for Charcot-Marie tooth. Now, if you look at the literature, they say that ankle-foot orthotics are really not warranted in muscular dystrophy. And I agree with them. Because the problem is not simply ankle weakness, they also have hip weakness, right? So if you fix the angle of the ankle, how do they get up from a chair? You know, it's very difficult. We get up from a chair, we flex our ankles and we push off, okay? If they're sitting on a chair, they've got to turn around and try to push off the chair. But it really doesn't even help them walk because their plantar flexors are very strong and their dorsiflexors are weak, but bracing it does not really do them any good, except maybe weaken their plantar flexors. So the best thing for these kids is to move the tibialis posterior. It's the best thing. But for Charcot-Marie Tooth, it's another matter because they develop cavus deformity. They have a lot of pressure on the metatarsals and on the heel, and you know, you probably know this. I'm not telling you anything you don't know. You want to redistribute the weight bearing on the whole foot, and plus they often have flail ankles. Sometimes they get a triple arthrodesis, but if not, then they almost all need ankle foot orthotics in Charcot-Marie Tooth. So now the patients always ask me about exercise. Well, Dr. Delatour, who was the chairman in Maryland, I think at Johns Hopkins at one time, did a study where she took Duchenne kids and gave them a nickel for every time they extended their knee with a weight on the end. These were ambulatory kids, and she lost a lot of money, and the kids got 70% stronger. So the bottom line is this. If you have greater than anti-gravity strength at a pivot, you can increase the strength by resistance exercise training. That's the bottom line. However, if your muscle strength is less than anti-gravity, if you exercise the muscle, in theory, you're only overworking the muscle and you may actually get more atrophy. And this came out of Philadelphia. In fact, Jefferson, who's my friend there, who am I thinking of? The guy who runs the rats. Oh, come on. He's at Jefferson, I think. He's not here. In fact, when he gives the oral boards, he tells people to insert the needles in him. And you better get the muscle right. You know? Herbison, that's right. Everybody knows that story, right? Yeah, right. Herbison, right. Yeah, he also did many studies on running rats and with muscle weakness and this and that, and he reported about the atrophy if you overwork the muscle. So if you use exercise, resistance exercise training, you can increase the strength of these muscles by as much as 70%. However, does that mean that your strength lasts longer? Or when you lose gravity strength, anti-gravity strength, maybe you lose it at the same time. Or maybe you're overworking the muscle and you lose it sooner. See, nobody really knows. Nobody really knows. So I don't, my patients, if they like to exercise, I tell them there's no reason to think that they're harming themselves, but there's no great evidence that it's benefiting them either. I mean, that's what I tell my patients. I had a woman come to me from Italy, and she had, I think it was FSH, but it was very mild, and she was just diagnosed, and she was very depressed. So I said, why are you so upset? This is the mildest neuromuscular condition you could have. She said, well, I can't play tennis anymore. I says, you can't play tennis anymore? Why not? You can run. Says, yeah, but my doctors told me that if I play tennis, I'll get weaker. I said, you go back and you ask your doctors to show any medical literature that reinforces that. There is none. In my opinion, you can go back and play as much tennis as you want. You're not harming yourself at all. I'll tell you, the only time in my life I ever played golf, ever, I was on the Canary Islands with a physician there who every Friday played golf with his patient with FSH, an 80-year-old guy who lived in a magnificent mansion over the cliffs in Las Palmas de Gran Canaria. I mean, unbelievable. And this guy could not raise his arms at all, but he could wall up a golf ball because he had excellent deltoids and the biceps. So, and you know, he's not going to stop playing golf because he has FSH. Okay, so I mentioned that to the Italian woman, and she was so happy that she can go back and play tennis, you know. So disuse atrophy. Now, this is something I think you should know, that you need to put your muscles through 20 to 35% of maximum strength at least once a day to avoid disuse atrophy, okay? What does that mean? When you get up from a chair, you're putting your hip muscles through 35%, more than 20% of the strength, okay? If you lie in bed all day, of course, you lose 1 to 3% of your muscle strength and the muscles atrophy. But normal activities of daily living, you don't really lose strength except with normal aging. Now, what is normal aging? Well, we reach our physiologic plateaus at 19, And after 19 or 20, we lose more than 1% of every organ we have. Our vital capacities go down 1 to 1.2%. We lose, kidney, liver, heart function 1% per year. So by the time we get to 120, we haven't got much left, right? So people naturally do get a little weaker as they get older, but as long as you do your ADL. See, this is why when people have some sort of medical problem and they have complications and they're in critical care for weeks or even months, they get so weak that they can't breathe. And we routinely extubate these people to non-invasive ventilation. But of course, what happens to them? They end up getting trached. And they don't need the trach, but once they get trached, they have more complications and so on. So, I mean, they trach 80-year-old people. And the doctors don't really learn how to manage them non-invasively. It's really sad. It's really sad. And by the way, why does that happen? The main reason why this happens is because of the American medical system. The financial incentives are for invasive and often over-treatment and useless procedures, useless invasive procedures. They get, you guys know what an RVU is, don't you? Yeah, yeah. Well, that didn't exist when I was starting this, when I was doing this, initially. But now you get 12 RVUs for putting in a trach tube, and you get about a half an RVU, but for teaching patients how to avoid respiratory failure in the first place, And that takes a lot longer than putting in a trach tube, let me tell you. This is probably one of Jerry Herbison's images. I'm not sure, but maybe. It just shows that when you exercise weak muscles, you go into the damage area here. All right, I already told you that. Now, Fowler, Goodgold, and Vinos many years ago said, since we, UC Davis for 45 years has had the only model neuromuscular disease center, NIDRR, in the United States. There's about 9 model TBI centers and 9, but there's only one neuromuscular, and that's been at UC Davis for almost half a century. The main thing that they have studied is exercise for 50 years. And after 50 years, they can't conclude anything. I love the guys there. They're really wonderful people, but they can, after all these years, they can't conclude anything. So, 50 years ago, Fowler, Goodgold, and Vinos said, recommend that people stay active and if they exercise and they don't feel rested in the morning, they're overworking their muscles. So, that's what they recommended. Yes.
Sorry, can I ask one?
Oh, of course.
Do you know if there's any scientific difference in muscle pathology versus innovation?
No, there's absolutely none.
We're sort of taught that a human keep innovation and exercise to get innovation. Otherwise, you're going to interfere with the innovation process.
Yeah. Well, I recommend you ask Jerry Herbison that question. But, I think Ernie Johnson would have said there's absolutely no evidence of that. Now, if there is evidence of that, and I'm not aware of it, you're not aware of it either. But don't assume. Ernie would say that people think, that common sense is often wrong, And anyway, what is the rationale for that?
The acidic environment from lactic acid.
Okay.
Okay.
Was there a study?
Yeah, right.
It shows the lactic acid in rats. It sounds like that Herbison, right?
It's our, oh yeah, we got the part when we rotate here. So we recommend it for acute axonal pathology. You don't let the something anything besides functional transfers until you have the injury.
Oh, that's really severe.
Yeah, but I honestly, I doubt
greater
that.
than 90% axon loss.
Yeah.
Because then it says that you have the chance that you lose those axons that are reinnervated. If it's like 50%, it's okay because then you have a lot of axons still left. But if you only have like 10% or less of the axons left, then he doesn't want you doing exercise because he thinks that you lose that chance of reinnervation from those axons left. So it's only in severe axons.
There's a study that he actually refers to and shows that histological evidence.
All in rats.
Well, if it's true for rats, it's probably true for us. Some of my best friends are rats, but but all because in theory it seems that way, it doesn't necessarily mean that it's true. Because of course, if you don't exercise anything, you can actually feel what little you have left too. So honestly, I doubt you know, I don't know what to tell you. I mean, theories don't always pan out, you know?
And it's more like, it's not all exercise, it's strengthening, like
Yeah.
strong and big strengthening exercise. It's okay with some like anti-gravity stuff, but he doesn't want strengthening exercise.
Yeah, resistance.
Yeah.
No, I can't help you with that. I guess maybe in theory that's the case, but does it really matter clinically, you know? That's what I mean. I doubt that there's any evidence of that it makes a clinical difference. It's a very difficult thing to show, too, you know? I don't really want to talk much about inspiratory muscle training, but it really comes down to the same thing. If you use a trainer, the stronger you are, the better the effect. So in other words, if you have less than anti-gravity breathing muscle strength, respiratory muscle strength. Now, what is less than anti-gravity respiratory muscle strength? Well, generally it's about 30%. If you have less than 30% of vital capacity, then you're normally ventilator dependent anyway. And that's sort of like less than anti-gravity strength. Now, if you exercise those muscles, you don't get any benefit at all. So, but if you exercise muscles that are relatively strong, the higher the vital capacity, the greater the improvement in endurance. Now, what do I mean by endurance? It's maximum voluntary ventilation. So if you exercise patients with 80% of vital capacity, you get much better, what they interpret as endurance. So you can breathe, maximum voluntary ventilation increases. However, the vital capacity does not increase, maximum inspiratory pressure doesn't increase. So there's no evidence that the respiratory muscles get stronger by exercising them, but they seem to have better endurance. Now, does that make any difference? I would say no. Because why do people go into respiratory failure? They don't go into respiratory failure because they can't breathe. Everybody goes into respiratory failure because they can't cough. If you have COPD, you have air trapping. If you've been smoking and you destroy the connective tissue that holds the lungs together, you trap air in the alveoli, right? And you have air trapping. You understand that. Well, you also trap secretions. And if secretions get trapped in the lung and you cannot cough them out, bacteria eventually get in there and you end up getting pneumonia, okay? The same thing happens to neuromuscular disease patients. If they're too weak to cough out their secretions, they develop pneumonia. So when they get colds, you know, we have to help them cough. So my point is that by giving somebody more breathing endurance, even if you could increase their vital capacities, the reason that patients with neuromuscular disease go into respiratory failure is always during respiratory tract infections. Over 90% of the time, it's for that reason. So, you cannot really greatly increase their coughing muscle strength. What are the coughing muscles? The abdominal muscles and some of the intercostals, okay? Mostly the internal intercostals and the abdominal muscles. Now, even if you could increase their strength a little bit, it doesn't have a very clinically significant effect on cough flows. However, if you use mechanically assisted coughing, you could help them a great deal. Oh boy, I apologize for the quality of these images. Somebody at Kessler made copies of my initial images and did an incredibly lousy job. This is unbelievable how he turned good material into images like this, you know? Well, anyway, this basically just shows that the higher the vital capacity, the better you can increase their maximum voluntary ventilation. So exercise in summary, avoid overuse atrophy. You can exercise, you can strengthen muscles that have greater than anti-gravity strength. Electrical stimulation is not useful. In England, they had 3 studies a long time ago that showed for the same kind of Duchenne patient that you could increase their strength by 30% with electrical stimulation. But by exercise, you can increase it 70%. So why would you do electrical stimulation for muscles? You know, likewise, there's a lot of the people who make diaphragm pacemakers, which is a type of phrenic pacemaker, market it to everybody. Critical care services, to ALS patients, muscular, it's totally useless. It's totally worthless. Why is it totally worthless? Because you can never get more than 25% of volume with a diaphragm pacemaker in neuromuscular disease that you can with a normal breath. So in other words, if your inspiratory capacity is 3 liters, the most that a diaphragm pacemaker will give you is 750 milliliters. Now, 750 milliliters is a normal tidal volume, okay? If you put that in somebody with central apneas, during sleep, of course, the pacemaker will cause obstructive apneas, but it will relieve the central apneas because it would provide that 700 milliliters of air. However, if you put in an ALS patient and the vital capacity now is only 1 liter, the diaphragm pacemaker gives you 250, which is completely useless, okay? So the diaphragm pacemakers are totally worthless. Now, of course, they market it to everybody because the only market that it's really of any value for is the C1 or C2 quad. But most of those patients are dead before they even get to the hospital, you see? Plus, they have to compete with the Avery diaphragm phrenic nerve pacemakers, right? So the diaphragm pacemaker people compete with the Avery people, and the market. Now, what did the Avery people do? They also had no market, right? So they started pushing their phrenic pacemakers on COPD patients. And they said, oh, with you put a pacemaker in a COPD, and it relieves atelectasis in the base of the lungs because the diaphragm moves down. It's total nonsense. Total nonsense. When your FEV1, your forced expiratory volume in 1 second is less than 750 milliliters, your prognosis for 5-year survival is 30%. And with the pacemaker, it's probably lower because a lot of people die from complications of the pacemaker. You know, but just to make money, that's what they do. You know. So I mentioned you get scoliosis from paraspinal muscle weakness. Now, when I was giving oral exams, I would ask, why do you want to prevent scoliosis? And everybody, almost everybody said, to preserve respiratory function. It doesn't preserve respiratory function because you lose 4% of vital capacity for every 10 degrees of scoliosis. But these patients only have about 20% of vital capacity anyway. And it doesn't matter how much scoliosis they have, okay? Their muscles are so weak, the diaphragm just, so they're not losing more vital capacity. But what does scoliosis do? For one thing, it impinges on an enlarged heart. The patients have cardiomyopathies. You do not want the spine pushing against an enlarged ventricle, okay? The worst thing about the scoliosis is pain. They're sitting on one buttock, you prop them up in the wheelchair, they're on one ischial tuberosity, and with 60 degrees of scoliosis in the thoracic, in the lumbar spine, you're getting radiculopathies. They have, whenever they sit up, they have severe pain, plus their ribs go into the belly on the concave side, right? And then, of course, they can't sit also. So they shrivel up like pretzels. In fact, I should have put an image of one of my Eastern European patients. I think the patient was from Macedonia with muscular dystrophy. He never had scoliosis surgery, and his mother's got to carry him everywhere because they can't put him in anything, you know? So the other thing about that, of course, you can get pressure sores, but it prevents you from using the intermittent abdominal pressure ventilator that I showed you in that patient with zero vital capacity. So in other words, if you put this girdle on with the air bladder inside it, and you hook it up to a ventilator, but your diaphragm is like this, it can't move the diaphragm to ventilate the lungs. So that's just another option that's taken away. So if you have a tighter iliotibial band on your left side, you see how the convexity occurs, right? It comes out that side. Now, in the 1950s, there was a French professor, a doctor by the name of Demos. He had the hypothesis. They didn't know what caused muscular dystrophy at that time. So he hypothesized that it was a microvascular problem. So he took all the kids when they were diagnosed, put them in a big institution, put them in hydrotherapy, hot hydrotherapy all day long, and gave them therapy, stretching, and he gave them vasodilators. And this is the result of one of those kids, okay? Severe scoliosis and death by the age of 18. And this was literally one of the kids in his institution. It's totally, and what they do is they see the older kids die when they're 18, and they're maybe 11 years old, and they say, oh, I got another 5 or 6 years to live. How depressing can you get? How depressing can you get? This is a patient who is from Florida. And when he was 15, he went into respiratory failure down there. And of course, they couldn't extubate him. So we had him transferred to us. And we extubate all these patients routinely to non-invasive ventilatory support. We're still the only place in the United States that does this, I believe. So then he went back to Florida. And he came back a month later for scoliosis surgery. Now, his vital capacity was 80 milliliters. That's 2%, less than 2% are predicted. Not 40%, 2%. So our orthopedic surgeon did his Luke rods. We had him intubated the next day, and he went back to Florida again. Now he's about 24 or 25. So this was like 10 years ago. And he hasn't had another hospitalization since. And he uses his ventilator pretty much only overnight. I mean, he does use it for periods during the day too. His vital capacity went up to about 120, but it's like 2%, you know? It's very, very low. He really can't breathe very long without his ventilator. I guess I mention it here because the usual indication for demanding a trach before you operate is to have a vital capacity under 40%. Most orthopedic surgeons would not want to operate on him or anybody with a vital capacity under 40%. They often say, oh, you've got to get a trach first because we're not going to be able to extubate you. That's because they don't know how to do it. You know, they don't read my articles, whatever. Well, literally, I'm not joking, you know. So Luke rods. Lukey is a Mexican physician who designed this system. You know, before Luke rods, there were Harrington rods where they would do the spinal fusion, but you'd have to wear a cast for 9 months. With Luke rods, you have wiring to each lamina to these 2 rods that go into the pelvis, and they strip the spines and make matchsticks out of them and fuse the spines. And so the rods hold the spine stiff so that the fusion can set, and they don't need any casting. See, that's actually how they put these strips across the spine, and that's the Lukey procedure. So these are all kids who had surgery. Now, cardiac involvement, you've got the myopathic process in muscular dystrophy. You have deconditioning, and you have core pulmonality. When patients are given oxygen, their CO2s go up, and they develop core pulmonality, and which is always preventable. I've had many patients come to me with core pulmonality. I put them on non-invasive ventilation, and then their echoes normalize. So they have EKG abnormalities that resemble myocardial infarction, but it's normal for them. And their ejection fractions are all over the place. Now, this was a study from Ranchos Los Amigos some years ago, and it shows that the left ventricular ejection fraction, there's no relationship between that and age. So you can be in your 40s with a good ejection fraction, or you can be literally 10 years old and have 20% ejection fraction. The youngest patient in the medical literature to die from heart failure with Duchenne was 11. And the youngest patient to have a low ejection fraction was about 9 or 10. But that's extremely rare. I've never had anybody like that. But certainly at 12, it is possible. And there are kids who go into heart failure by 15 to 17 years of age. Others don't go into heart failure in their 40s. So, you know, that's how variable it is. But the more aggressive cardiologists are recommending, I'm a Muscular Dystrophy Association clinic director, and they are recommending that the patients receive cardioprotective medications, in particular beta blockers and ACE inhibitors. And I actually published a paper on this in 1999, and in fact, we showed that the ejection fraction goes up an average of 40% when you put these patients on them. Even if their blood pressures are low, you put them on this, and their ejection fractions go up about 40%. See, so it's very important. Now, neuroendocrines are atrial natriuretic protein, brain natriuretic protein, and norepinephrine. We're not really sure where these things come from. These neuroendocrines come from, maybe from the heart, maybe from the adrenals. We're not really sure. But when there's stress on the heart, they go up in the blood. And these can be used to monitor the effect of your cardioprotective medications. So beta blockers, ACE inhibitors. We really don't use digitalis anymore. And we showed that how the neuroendocrines decrease when you do this. Other rehab problems, psychosocial, constipation. By the way, the best thing for constipation, let me see. Well, is the Hoyer lift. You probably use this on your spinal cord patients at Moss, right? Well, let me tell you, the Hoyer lift is great for muscular dystrophy patients, polio patients, anybody with constipation, because the bowel movements are literally 10 times faster from a Hoyer lift than they are lying in bed waiting for, digital stimulation or suppository or something. They need to be turned every 2 hours, but I don't have to tell you that. Twirling, sitting support, yeah, I don't have to tell you any of this. Let me see. Now, in neuromuscular disease, gastric emptying times are delayed. Normally, you shouldn't have anything in your stomach 1 hour after a meal, but the intestines can all be slowed, and prokinetic agents can be extremely helpful for these patients. There are many prokinetic agents now, erythromycin, Reglan. Some senator's child had a bad effect with Reglan, but actually I use Reglan a great deal for my patients, and it works very, very well. But anyway, they can be very helpful. Condom catheter drainage for the active Duchenne patients or any muscular dystrophy, neuromuscular patients who are working and can't get help of urinating. Women, of course, have a problem. I still do not know any good solution for this for a woman. We have maybe the only board-certified urologist and physiatrist in the country, I think, Todd Linsenmeyer at Kessler. And he has, every time I've asked him about this, he says, no, there's nothing, for women. This is a seat that comes out of the car to facilitate transfers into a car. There's the Hoyer lift. And the Duchenne patient on the Hoyer lift for the bowel movement, BFO. Robot arms. I got to tell you something about robot arms. These are little robot arms. Patients go to restaurants and use them. And patients with no finger movement, they use their toes to operate their environmental control systems. This is for SMA type 1. A patient, her parents devised this system. She's now 21 years old with SMA type 1. And this is a chin control motorized chair. And let me see, what is she doing? Yeah, she's got mouthpiece ventilation, a page turner. Yeah, you know all this stuff. Eye gaze system, which you must know now, right? You know what an eye gaze system is, right? Okay. Now, this is something I bet you don't know. This is called a JACO. You know what a JACO is? Have you seen one of these? It's a robot arm. It's a. Excuse me?
This is at the Mass General.
No. It was on 60 bits.
JACO was, or the Mass General one?
No, they're doing this at Mass General.
No, I think it's a different arm.
The
Braintree. No, there was a robot arm that came out of Holland, and they worked with people at Mass General with it, but it was cumbersome. Compared to this device here. The man who devised this has a son with muscular dystrophy, so he made this thing in Quebec. And I think this was their competitor, and I think that this is the device that has basically taken the market. Because in Holland now, their insurance pays for these things, because when you use one of these arms, you don't need an attendant. Now, they don't pay for nursing care in Europe in general, okay? But if you're severely disabled, they pay for attendant care, which is, of course, a lot cheaper, like 6 times cheaper. But if you have one of these arms, and if the patient says, okay, well, I'll take the arm, and I don't need the attendant, well, it pays it off, you see? So in Holland, I know, the insurance system there, the government pays for these JACO arms. And you can do just about everything with this arm. Now, I'm telling my patients who have them that I would love to see you transfer yourself and have a bowel movement with this arm, because that would be it. If they could do that, then obviously they don't need anything, okay? But so far, I have not been told that anybody's been able to do that. Now, is it possible? I don't know. I have my doubts.
That's really cortical implant.
Cortical implant?
That's what she has on the top of her hip.
Oh
Yeah,
boy.
That's from BrainGate.
Oh, I'm sorry. Oh, I thought this was a JACO arm. No, you're right. Yeah, this is the cortical implant to operate I'm sorry, but what is the JACO arm? It looks like it. I think I put the wrong image in there. I wanted to put something else. There's a robot arm that's made. It looks very much like this, almost exactly like this. Wow. It looks very much like this. That's all I can tell you. But this is the cortical stimulator. Oh, yeah. They use the alpha waves and everything. Yeah, they say it's not very efficient. I've never seen it myself. Oh, they control it with a motorized wheelchair control, so joystick usually. Anybody that uses a motorized wheelchair, whatever you use for the motorized wheelchair, you can operate the JACO with. It's JACO. This is a rocking bed. Now, a rocking bed is an old ventilator. It moves the diaphragm up and down, ventilates the lungs, but it's also good for ADL because my married patients used it to have sex, you know? You put the male on the bottom, the female on the top, connect them, and you know, you go from there. By the way, oh, by the way, you can adjust the frequency and the amplitude, okay? So, you know, I showed you somebody before, and his wife, his second wife, was putting on his pneumo belt. You know, you'll see him again, I'm sure. Well, his first wife, also, I think she had multiple sclerosis. And they got married, lived with an attendant. And the attendant would dress him, bring him to work, and they had a rocking bed. He worked full time, even though he had no movement below his neck. Zero vital capacity for 52 years. He worked full time. He was perfectly intact from the neck up, okay? And so he and Vicky got married, and they had the rocking bed, and the attendant would, you know, help them out there. And the attendant would get him to work, go back, and the attendant had an apartment in the same apartment building. Now, his wife, Vicky, who had severe scoliosis, was 24-hour event dependent, and had a little bit of movement of her biceps, but really nothing significant with her hands, you know? And she didn't have any movement of her legs. She got cancer, and she died from breast cancer after 2 years, where they were married for 2 years, right? Now, after her death, the attendant came to the patient and said to him, admitted to him that he was having an affair with his wife, okay? Now, I addressed comments to the women here. Now I'm gonna address comments to you, okay, to you guys. Remember something, it doesn't matter if your wife has severe scoliosis, is respirator dependent, and totally paralyzed. You gotta keep your eye on it, okay? It's not because somebody is disabled that they don't have normal vices, okay? It doesn't matter how severely disabled you are. These guys and women, they have the usual vices that the rest of us have, okay? I'm just warning you. You guys are young, naive, you don't understand these things. Someday you'll say, oh, he was right, you know? This is a rock group called the DMD, Dream Music Directory. 4 of them are mouthpiece ventilation. This is Makoto Takahashi. I have 2 of their CDs. They program the computers to play the instruments, and they sing. And their music is absolutely excellent. It really is good. Okay.